Now we're gonna talk about Swan-Ganz catheter, or we call it pulmonary artery catheter, okay? And to start with, this was discovered by doctors Jeremy Swan and Gans. And probably they were celebrity too because they worked in Cedars-Sinai at that time during 1970s, before you were born. So this is your Swan-Ganz. It is 110 centimeter long, okay, from the tip to the edge here. And as you see, if you look at the markings, go pick up your Swan-Ganz, please. Look at the markings. You have one thin, and then you will find as you go along a thick one. So this is increments of 10 centimeter. So as you go on, you will duplicate, triplicate, and then you have 4, and then the thick one is thicker, and that's your 50. And then if you add another 10 after that, that makes a small, thin, and a thick one that makes 60, and so on and so forth. Okay, you see everyone? Yeah? Now, this is heparin coated. Remember, this is a foreign material. The body immune system can reject this, so that it is heparinized with just a tiny bit of heparin, which I don't think it can damage, or do any harm. It's just to protect for clot formation around it. And it is made of polyvinyl chloride material. Okay? So, let's go to the physical aspects of it. There are 5 ports that you are looking at. They play a big role in getting you numbers and diagnosing and all that. Let's do the first one, the yellow one. The yellow one is the PA port, or what we call the distal port. Why is it distal? Because it's away from the incision side. So if you inject saline, you will find out where it's coming out, the fluid out from. And I want you to know, so you know where exactly, when the catheter is in the heart, you will exactly know where they are located. So that is your PA. So the next one is your thermistor wire. As you could see, there are 3 wires, or is it 3? Inside, and what the function of this, and the end of this is somewhere here. There should have a small, I could see the black there is inside. You could see a black like a dot inside, that's signifying that's the end of the thermistor wire. And this should be at the pulmonary artery, lying at the pulmonary artery. And the function of this thermistor wire is to monitor the change in temperature of the blood in that position. So pulmonary artery, when you do the cardiac output fast, right? So the saline goes fast and mixes with the blood in the pulmonary artery. So that change in temperature of the blood, the thermistor wire picks it up and correspondingly gives you the corresponding cardiac output. So that is your thermistor wire. So next thing, let's do the CVP. The blue port is the central venous pressure monitoring port. And I want you to inject saline in there and see where it's coming out from, the fluid. So it's about 30 centimeter, right? Right. So this is where your fluid, when you do your cardiac output, starts, because that's where you push, right, the saline. And then from there it goes to the pulmonary artery. And this is also to monitor your central venous pressure. Okay, you see that? Huh? Okay, the next one is your balloon. So if you see the balloon here, of course, if the red lines are in line to each other, that means it's open, the lock thing. So I want you to put it together to open it. ready for deflation. What I want you to do, now this is what we call a specific or special syringe made for this. And it has a stop inside, so you cannot go any further, the plunger, okay? So you can only inject 1.5, no more than that. So this is where the balloon is being inflated. So if you look at the tip of it and you inject air, go for it. Let's see what happens. See, when it is inflated, what happens to the balloon? The balloon surrounds the tip. Are you with me, guys? It surrounds the tip. Now remember, if it's deflated, it's a very spiky, very what you call hard. And without this, if it's being inserted into the heart and it touches the ventricular wall, it can create irritability and can cause arrhythmia. So when you inflate that, this helps, in preventing arrhythmia. So that's a double duty, right? So when do we use this? We use this balloon because, remember, this catheter is a flow-directed catheter. So what does that mean? Flow means flow of blood. Directed is the direction, okay? Flow-directed catheter, meaning with the pressure of blood pushing this, so it helps in inserting the swan all the way to the pulmonary artery, okay? So that's another function of the balloon. So that is your what do you call that? That is your syringe and the balloon. And next is your white port. The white port is what we call VIP port. So what does VIP stands for? Some people, they call it variable infusion port. Some people, they call it venous infusion port. So I want you to inject some fluid in there. And you would see that it's very close to CVP. So when you're using, this is a port that you can use your drips. You can put all the drips as long as they are compatible to each other. And so that the drips that you're giving the patient comes out close to the CVP. All right? So that is your VIP port. So that is your mechanics. Now, when we do your cardiac output, there are 3 things that we always look for, right? So what are we really taking? What measurements are we taking? Now remember, we talk about cardiac output. It's the amount of blood that is being ejected, particularly on the left ventricle. And the normal of which is 4 to 7. Now let's talk about cardiac index. Now cardiac index is basically a cardiac output. However, this cardiac output is adjusted according to the BSA of the patient, body surface area. And mostly in MSICU, we use this a lot because this is, again, adjusted according to the patient's build. And of course, the BSA is based on the height and weight. So you have to have your height and weight plugged in your computer in order to be able to do the BSA and therefore to be able to do cardiac index. So normally the cardiac index is 2.8 to 3.6 liters per minute per. So SVR is the systemic vascular resistance. So this ties up along with the afterload. Remember, we talk about afterload resistance. And the SVR, remember, the normal is about 800 to 1200 dynes. So with SVR, this can tell you whether it's so tight When it's tight, what happens to your SVR? Up, right? More than 1200. If it's vasodilated, you see the SVR down, low. So that will tell you how tight the vessels, the tissues, the vascular beds are when we talk about SVR. So that is really the informations that you mostly get from doing a cardiac output. Talk a little bit about ejection fraction. Now, I'm sure you hear about, oh, the ejection fraction of this patient is 50. So basically, I just want to let you know what ejection fraction is. It's really a good reflection of ventricular function. And as you know, when the ventricles contract, not full 100% is being sent out. There is like 25% left in there. And that's why, they categorize the normal being 50 to 75%. It's a percentage. So if you are in that category, or if your patient's ejection fraction is between 50 to 75, that's a good sign. Okay? It's a percentage of the left ventricular function. Also, I want to mention is the sheath, this wrinkly sheath here. They call it guard. Well, Melissa will talk to you more about the details of this. I'm just giving you a rundown. It will be reinforced by Melissa later. So this sheath is basically keeps the Swan catheter inside sterile for the purpose of whether to advance or pull out, we keep the tube sterile. Because we cannot push it in a catheter in the body if it's unsterile. So this is the importance of the sheath right here. And the next thing I want to tell you is this little guy here that looks like an L shape. This is what we call introducer or cordis. Dr. Cordis invented this. And this is of course bigger than this because this is where the Swan-Ganz is threaded through. Now, as you see, there is a small and a big, longer one. This is about 4 inches, and this is about 6 inches. One goes to the vein right here, and one goes outside. So it's like this, it looks like this. And before the swan is inserted, of course, this is inserted first. Now, there is a diaphragm here that if it's not punctured, it's well tight. There's no way air can get in. However, if the swan, this helps in guiding the swan to go inside. So once it's punctured and it's not airtight. And that's why when this is removed and discontinued, we have to use a cap to keep it airtight to prevent from bleeding and prevent from air embolism. So what are these being used for? It's used for blood transfusions, for rapid IV boluses, IV drips, and also you can connect this to CVP to give you an idea of the central venous pressure of the patient. So to sum it all, I would like to tell you about the rule of 10. And it's very easy to remember. We start from if the swan is inserted via subclavian or via jugular, the rule of 10 applies by. If it's 20 centimeter, you know it's in the right atrium. If it's 30, it should be in the right ventricle. If it's 40, the markings, remember we talk about markings? If it's 40, it should be in the pulmonary artery. And when it's 50, that's when you are wedging. In other words, you do not want this catheter more than 50-55 centimeter inserted in the patient. Okay, otherwise, you inform the doctor, and that's why it's important that you check the markings on the swan as your assessment, so you exactly know where it is. And if it's inserted through the femoral, you add another 10. Instead of 20, it should be 30, 40, 50, 60, because it's farther down the distance. And of course, before you insert this, make sure that you look over the patient's labs because you don't want bleeding and arrhythmia to occur. So that is my lecture today. Now, to sum it up, remember that all these lines are looking for something, and your transducers are the eyes for this. Okay? They have eyes, just like a telescope, that they're looking forward to obtain information. Okay? To obtain what you're looking at. And this is basically what the Swan-Ganz is for. And of course, chest X-ray is a mandatory procedure to be done once it's inserted, because you want to make sure that it's not going anywhere. So that is my lecture. I hope you have gotten something from it.